wet afternoon to the September meeting of the Integrated Care Board meeting. It's great to see everybody. Just by welcome and apologies, just before I start, I just wanted to extend a very warm welcome to Simon Constable, the new Chief Executive at University Hospitals of North Midlands NHS Trust. Simon's recently joined us. Simon, it's great to see you, and we very much look forward to working with you going forward.
Thank you, David. I'm very, very pleased to be here. Nice to see you all. Thank you.
Okay, so just by introduction, Staffordshire and Stoke-on-Trent Integrated Care Board meetings are meetings in public. They're not public meetings. The meeting is being recorded and will be available on the ICB website after the meeting. When we get into the meeting, I just ask if everybody other than either myself or presenters put their cameras off so we can see the screen. And if you could ensure that your microphone's on mute, we should get a good sound quality during the course of the meeting. I'll invite questions from members of the public at the end of the meeting. And for board members, if you'd please raise your hand on Teams to direct questions, I'll make sure those are taken. Can I just ask whoever's on the call just to go on mute, please? We can hear you on the call. I will also give an opportunity for any question at the end of the meeting to be asked, and we'll address those. So by apologies first, if we could just take the apologies I've got registered. We've got Elizabeth Disney and Nikki Harkness. Nikki, thank you. You're representing Elizabeth. Megan Nurse, Chris Eibel, Shokat Lal, Bucky Adiemo, and Eric Gardner's representing Bucky. Mish Irvine and Gemma Trina is on the call, and Neil Carr. Those are the apologies I've received. At enclosure 1, we've got the leadership compact, and I just want to reinforce the importance of this document in terms of its importance in the way that we conduct all of our business and conduct ourselves. And interestingly, a number of us were on a regional session yesterday with Dale Bywater, chairs and chief executives from across the region. And it was an opportunity to really reflect on system working and reaffirm the importance of that. And sitting there in the audience, I was just thinking of the importance of the compact and how it does guide relationships and our business across the piece. So please do take note of that. We've got the conflicts of interest register at enclosure 2. Just pause there if anybody's got any conflicts they wish to raise on any item that's not been referred earlier on the agenda. If not, we'll go to enclosure 3, the minutes of the meeting that were held on the 18th of July, and we'll take those for accuracy first if we can. So if we can go to page 1, page 2, page 3, page 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Is everybody happy to receive those as an accurate representation? Thank you very much, and thank you, Lisa, and everybody for producing those. Item 5, enclosure 4, is the action log. Heather, I think there's just an update on the birth trauma inquiry report that you wanted to give at this meeting.
Yes, thank you, Chair. Just to say, for anybody who's not aware, just a reminder as well, the all-party report into birth trauma was published earlier in the summer. We've spent a significant amount of time reviewing that in line with, or reviewing local services in line with the findings of that. Early next week, we have the first joint local maternity and neonatal system meeting with Shropshire, Telford and Wrekin. One of the agenda items for that meeting is a peer review of the self-assessment against the findings of that report. So it's only just going through the LMNS process, so it's slightly later than expected in terms of coming as a written report to board, But I can assure everybody here that we have reviewed that and we'll have that relatively independent peer review after the LMNS board meeting next week, after which time it will come through a Quality and Safety Committee and then a fuller report back to board. So hopefully that provides sufficient assurance.
Thanks very much, Heather, and we'll take that off the action tracker and bring it through, as you say, the governance of the ICB for future reports.
Thanks
very much. Everybody happy to receive that? Sorry, did no? Okay, I thought somebody had asked a question then. Okay, so we'll move into item 6 if we can. Tracy, can I just come to you to ask, have we had any questions in advance of the meeting?
Yes, we have, Chair, and we've had questions from Mr. Ian Syme. So I'll read the first one. It's on dentistry. Several months back, I asked how the ICS-ICB will be ensuring access to dentistry will consistently improve and how the ICS will make sure all dental funding allocation will be spent on improving NHS dentistry services. I'd highlighted that dental problems for children were now the single greatest cause for children being admitted to hospital. I was told that the ICS-ICB was waiting the formulation of Midlands dental strategy. What is the state of play of the strategy? Is that strategy also addressing the significant issue around children's access? And also that notes today in the ICB papers that there is present an underspend in dentistry. Can the ICB assure that the ICS-ICB will be utilising dentistry allocation in full for dental services?
Thanks, Tracy, and Ian, thank you very much for the question. Paul, I'll come to you, I think, to take that.
Yeah, thank you very much. Thank you, Chair. Ian, 3 parts to that question. The first one is about the strategy. We now have the West Midlands strategy in draft form. That's going to be launched next year. We're hoping to bring that to the ICB board in January next year, alongside a Staffordshire Stoke-on-Trent local dental plan that we're currently working on. The local plan's been informed by a health equity audit that's been done for Staffordshire Stoke-on-Trent to make sure that we're addressing the needs of the whole population. So in terms of the strategy, yes, it'll be coming to the board hopefully in January of next year. Second one was, sorry, Chair,
no, carry on, Paul, sorry.
Second part of the 3 was about children's access. So the strategy and the local dental plan that we do will address the whole population, as you would expect. But we will, once we've done that, be specifically looking and doing a very deep dive on children's dentistry. And we'll be bringing something to the Children's Portfolio Programme Board as soon as we can after that launch. And then the third part, Chair, is about the underspend on NHS dentistry. Mr. Syme will know that dental budgets have traditionally always been underspent, and that's due to the complex nature of the way that dental contracts work and the under-delivery of those contracts. The aim of the local dental plan will be to make sure that the budgets are invested in the right areas going forward, and we do that recurrently to improve dental access in the future for the local area. So hopefully that will all come into play next year once we've got the local plan, the local strategy, and we take that forward.
Thanks very much, Paul. Tracy?
Okay, thank you, Chair. The next one is on maternity. Mr. Syme says he noticed from UHM board paper earlier this year that various user lay representation on maternity bodies, including maternity voices, does not reflect the general population or the local population. I've since inquired about this and been told, yes, that it's problematic and it's not just local to UHM. How is this lack of voices from significant sectors of our local population being addressed, certainly in the light of various inquiries re substandard maternity services, where a consistent theme is women have overwhelmingly said they've not been listened to?
Thanks very much, Tracy. Heather, are you taking that one?
I am indeed. Thank you, Chair. And thank you again, Mr. Syme, for your question. Very, very valid question. We're working really hard, as you know, we're working really hard across the LMNS on levelling up access to both services and support. Our Maternity and Neonatal Voices Partnership, working to bring seldom heard groups through various community groups, through community leads and through listening events. The MNVP, so the Maternity and Neonatal Voices Partnership Chair, focuses her engagement work with seldom heard groups. And there's also been an expansion of the Maternity and Neonatal Voices Champions role across the ICB area, with a clear work plan for 24-25 to include hard to reach groups. The MNVP, so I keep saying it in abbreviated form and I apologise, the Maternity and Neonatal Voices Partnership also continue to work collaboratively with Derby and Derbyshire's equivalent, and a UHM inclusivity visit has recently been completed with a number of women feeling that people that reflect the local population engaging in that visit. A report's also been shared with recommendations for improvement, and an action plan is in development. There's a 15 steps visit for UHM maternity due to take place in October, and that will include us interfacing, meeting with women who use the services and who do reflect the population. We've also, as an ICB, funded an equality diversity lead midwife at UHM, with a view to that person working really, really closely with the Maternity and Neonatal Voices Partnership. We're also refreshing a specific maternity equity and equality action plan to reflect the findings of all of the investigations and the high profile reports that you refer to, including the Ockenden report into Nottingham, the National CQC report, Embrace recommendations, which is maternity data that we receive on a regular basis, to make sure that we're tackling persistent inequalities to make care safer and equitable for all, but making sure ultimately that we're doing everything we can to listen to the relevant members of the population. Hope that helps, and if not, as always, I'm happy to have a further conversation.
Yeah, thanks very much, Heather, and we'll return to that as well as part of the quality and safety report that you'll present later in the agenda, just in terms of the considerable work that's taking place at UHM in that regard. Thank you. Tracy?
Yeah, the final question is about the capital programme. Lord Darcy's recent report highlighted the NHS Byzantine approach to capital spends and how the NHS lags way behind its peers' recapital investment. Is the ICS-ICB creaking capital programme being thoroughly reviewed, and when will that review, if there is one, going to be publicly reported?
Okay, thank you, Tracy. So is that Peter or Paul who's picking that up?
Yeah, I think me first, David. Yeah, so Ian, you're absolutely right. And capital is very heavily constrained in the system, and we absolutely welcome the comments in Lord Darcy's report about that, the need for further investment. And we do currently have a balanced capital plan. We'll go through that later in the current year. We have, as a result of a request by the NHS England, just submitted a 10-year capital ask, which we put forward. We understand that's going into the spending review and the 10-year planning process that's underway for the NHS. So we're hopeful that will lead to additional capital. And we find that we've also done some work recently on, as a system, how we would undertake prioritisation of capital to ensure that we make those decisions as a system and make sure we prioritise the capital for the areas that have the most impact in terms of patient improvement and also obviously financial improvement too. And finally, again, I'll talk about this in a bit, Ian, but we're underway with a piece of work looking at a longer term plan for the system, not capital, but a revenue plan. But as part of that, the clear steer of a number of our groups, particularly the health and care senators, that we need to be thinking about making sure that we inject capital into the right areas in order to release the opportunities that we can see for revenue, for example, digital. And again, we'll talk about that a bit later. So, Chairman, hopefully that provides an adequate answer for Ian.
Thanks very much, Paul. Tracy, can I just check, that conclude the questions we've had in advance?
That does, Chair. Thank you.
Yeah, thank you, Tracy. And Ian, thank you for your continued engagement and questions that you've raised with us today. So if we could move into enclosure 5, the Chair and Chief Exec's report. There are a number of key things that I wanted to pick out of this report. In a moment, I'm going to hand over to Peter, who's just going to give us about 5 minutes just on Lord Aradarsi's review. Ian touched on that in one of his questions, a really important review that's taken place that's going to guide the formation of a 10-year plan for the NHS. So we'll come back to that in a moment. If I could just pick up a few other important items I just wanted to raise. Just under 1.3, I just wanted to acknowledge the patient HSJ Patient Safety Awards, the 24 winners announced. And I was absolutely delighted to see that UHM have picked up 2 awards when you think there were 206 finalists competing across 25 categories. To actually pick up 2 of these awards was absolutely fantastic, and it's great to celebrate that. We've won quite a few awards across the system. I do think it's important that we note that. So they are there, the 2 awards there, harnessing human factors approach and the patient safety pilot project. Really important awards. Secondly, I just want to acknowledge under 132 Nurse of the Year, Staffordshire and Stoke-on-Trent's nurse facilitator Jill Boast has been nominated as Nurse of the Year with the Nursing Times. The awards will be held in October. Jill, fingers crossed, and we hope we get a really great result there as well. Just in terms of senior leadership changes, I've already welcomed Simon to the meeting. Just want to welcome for the next meeting Elizabeth Disney, who's joined us as our new Chief Transformation Officer from the 1st of September, and a warm welcome. And I also want to give a real thanks to Nikki Harkness, Nicola Bromwich and Helen Slater for taking on various additional responsibilities over the summer. All 3 have done an absolutely sterling job of keeping the ship upright during the period. And just to say goodbye and thank you to Steve Grange from MPFT, who's leaving the system to take up the post of Chief Executive Officer at Cambridgeshire Mental Health Services, and Chris Sands, the Director of Finance at MPFT, who's moving over to Burton. Lorna Clarkson left the role of the ICB Deputy Chief Medical Officer to move to Telford and Wrekin, Shropshire and Wrekin. And Mark Seaton has also retired from the post of ICB Chief Pharmaceutical Officer. So all the very best to those people for the future. Just wanted to note a couple of events I attended. Under 1.5, on the 16th of September, I went along to chair MPFT's Digital Prevention Project Awards, and they were absolutely fantastic set of awards, projects that they've put into place. We were joined on that day by NHS England's National Director of Public Health, Sarah Price, to really innovating awards that have actually come about without over-engineering them. Had an idea, got on with it, and actually implemented it. And the learning from those will come in due course, but some really great innovation demonstrated there. And secondly, I just wanted to say, early August, I had the pleasure of going around MPFT's forensic services and parent and baby services with Jackie Small, the chair, and it was great to go over to the Hatherton Centre and the Brockington unit and to meet the staff that I've identified there in the report, and I just want to thank them for everything that they're doing. In a future meeting of the board, Tracy, I'd like us to consider bringing forward a showcase really on forensic and acute psychiatry inpatient services for both combined and MPFT. Just to note the work that our staff do on a day-to-day basis to keep people safe in those environments. So with that said, Peter, can I hand over to you and just ask you if you would give us a summary and a flavour of what's in Lord Darcy's report and an idea of how we're going to engage with that going forward.
Yeah, thank you, David, and good afternoon, everybody. So firstly, I'd like to say or mention an omission in the report, which is that there are many thanks in relation to the transition period with Elizabeth Disney starting, as you mentioned, David, only a few weeks ago. The one omission is that Lynn Tolley stepped in and provided significant support around children and young people, the CYP agenda. So for the record, I'd like to show my thanks to Lynn as well. So in terms of the Darcy report, just a couple of things I'd like to mention. And I think, David, you mentioned a moment ago that we had a Chairs and Chief Execs regional event yesterday, which was quite timely, actually, in that I was fearful that perhaps we wouldn't get to talk about Darcy, the left shift, the strategic opportunity, really, that we've got now to the level that actually we have, both at national events but also the regional event yesterday. So I was incredibly pleased, really, that I suppose I'd describe it, the political will that's clearly there now that perhaps has been lacking for the last period of time, to focus on that left shift agenda, to move resource, capability and capacity upstream to be able to better prevent deterioration or ill health in the first place, and then ensure that we're proactive when poor health does come upon us. As I say, I think we've got a massive opportunity now to harness the political will that's clearly out there at a localised level. Of course, at the same time, there's a good reason why I think as a country we've perhaps not ever, let alone within the last few years, been able to truly embrace and deliver that left shift agenda. The fact is that's very, very hard to achieve when in truth you need to, what I would describe as double run both those proactive agendas, creation, development and implementation of those proactive and preventative agendas, whilst at the same time, of course, we have to deliver all of the stuff that we are at the moment around the reactive side of life, including, of course, the continuing work around such things as backlogs and financial challenges. So there's a reality that we have to somehow make sure that we can work within both of those environments. And yesterday was helpful in that, of course, it did provide some insight into how some other systems are in part achieving that. And I wouldn't want in any way, shape or form to suggest that Staffordshire aren't doing their part. I think the moment is absolutely upon us, nationally and locally, though, to springboard off that political will and ensure that we maximise that opportunity. Paul's going to talk in a few minutes around the medium-term plan that he alluded to a second ago, which gives us the opportunity to create a framework to define what our ambition is in that left shift. But I'm also mindful that the Darcy report talks of key, what I'd describe as transformational enablers that have been naturally lacking over the last perhaps 7, 8, 9 years, that I think we need to be extremely mindful of, inventive in part to get around, but also at the same time probably demand more of those at the centre in relation to almost permission, authority to increase. So management within the NHS is, for me, a great example of almost a political football that's been kicked around for the last, well, forever perhaps, but particularly the last 10 or so years. And the Darcy report's highlighted, of course, that we have reduced our management capacity, particularly in the 2012 reforms, but it hasn't yet come back to levels pre-2012. And on one level, it's obvious that management's absolutely critical to enable us to transform, to change how we do things. We've got more clinicians than I think we've ever had. Again, the report indicates that. But this complication of sort of narrative between we've got far more clinicians, but actually we're less efficient than we were. Well, actually, Darcy's presentation of the sort of rationale and reasons behind that, when you read them, they become quite obvious, actually. Clinicians are there to treat patients, to do activities day in, day out, to work with the population for prevention, treatment and diagnosis. They're not naturally there to take a step back, understand what isn't working as well as it can be at the moment within the NHS and how fundamentally we can change things. So actually, the truth is management is hugely important. So redressing that balance, I think, is key. The capital piece is a real challenge. I mean, thank you, Ian, for your question a moment ago and the response, Paul. It is going to continue to be tight, I suspect. Obviously watchful of the autumn statement coming up, and perhaps a little bit optimistic, but we'll see. But that is a challenge. But we've got to think beyond, I suppose, the fundamental challenge that the money will provide, and say, how can we, within the resources that we've got at the moment, do things differently, act in a better way, which is really tough to do. But I think that has to be the expectation of us within the system. So a load of almost quite cathartic narrative that came through the Darcy report. Some challenges, some questions for us that we are still to answer, I think. But I suppose the final point I'd make is what I opened with, which is the imperative on us all to piggyback on the refreshed political imperative around the left shift. I'll leave it there, David. Yeah.
Thank you very much, Peter, for that very helpful summary. I'll just pause there in case any member of the board wants to make any comment. Julie?
Thanks, Peter. And yes, I also was able to be there yesterday. I think that double running, we can't underestimate how difficult that's going to be. But the other thing for me as well is this transformation and doing things with the same amount of resource relies on partners, absolutely. And funding restrictions with local authorities and the voluntary sector as well. So we have to be mindful and really work together to help each other.
Yeah, thanks very much, Julie. Yeah, key points again that, as you say, came out of the leadership summit yesterday. Okay, so thank you very much for that, Peter, and for presenting that. We'll receive the report and be assured that we're working on each of the topics that are raised within that report. Heather, if we could move into enclosure 6, the quality and safety report now. And then on conclusion that, Josie, if I could just ask you to take enclosure 7, and I think there's enclosure 8 as well, 2 reports from you.
Thank you very much, Chair. Usual format, so people will be familiar with the way we present this information. Just as always, a couple of things I particularly wanted to draw out. One is a couple of positive news stories, really. So first of all, on the LEADER, the Learning from Deaths of People with Learning Disabilities, I've been at this board many times and reported about a backlog in reviews based on the fact that we took good advice and with every good intention commissioned somebody else to undertake these reviews for us. We, as you know, are now in a place where we withdrew from that commitment and temporarily in-housed the arrangements to provide LEADER reviews. And I'd like to begin by saying a massive thank you to every member of clinical staff who's volunteered to come forward, undertake what is fairly comprehensive, lengthy training, and who have, on the back of that, supported us to complete those reviews to the point that we now have none in the backlog. So the backlog has completely gone. That's a really good news story. And we have sufficient capacity through bank reviewers and existing staff who are willing to complete ad hoc reviews that we can continue to stay on top of that number. So really important, very positive progress, and important in terms of making sure that we're maximising our opportunity to learn from every single learning disability patient who does die at any stage in their patient journey. So very key progress there. As you know, I referred to the joint local maternity and neonatal service meeting as part of my response to that action from earlier in the year. Just to be clear, and for anybody who's not fully aware, the requirement to not operate a local maternity and neonatal system that only covers one provider was part of the initial immediate actions from the first Ockenden review. And locally, we'd argued that actually, because we work not only with UHNM but also with UHDB, with Derby and Burton and with Royal Wolverhampton, and to a lesser extent with some other providers across the border, that we were fulfilling that requirement through the work that we already do. There's been some challenge on that, and we've been asked if we would link up with Shropshire, Telford and Wrekin So we are, and from, as I said earlier, from next week, we're having a bi-monthly joint local maternity neonatal service meeting, which will be jointly chaired by Paul as our medical director, Chief Medical Officer, I beg your pardon, Paul, and Lorna Clarkson, who we talked about earlier, who's now gone over to Shropshire, Telford and Wrekin as their Chief Medical Officer. And that will be a rotating chair, and myself and Vanessa, who's the Chief Nurse over in Shropshire, will play a pivotal role in making sure that that carries forward every opportunity to learn from each other. The massive benefit that that brings in terms of peer support and review is, it can't be overstated really. And that's the reason why the paper that I referred to earlier around the birth trauma is one of the first agenda items, to make sure we really are taking maximum opportunity to learn. So we'll be updating further on that once those first couple of meetings have taken place. Another positive news story, and I think this is probably old news to most people now, but just for anybody who isn't aware, and for completeness from a Quality and Safety Committee point of view, the CQC did revisit UHNM's County Hospital site and have formally written to remove the Section 29A that have been in place for some time. So the only outstanding one now relates to maternity services, and we look forward to maternity services being reviewed in due course. And then one last point to raise, but one really, really important point to raise, relates to the tragic events that unfolded in Nottingham last summer in relation to Valdo Colkane, the young man who tragically took the lives of 3 innocent individuals. CQC have undertaken a comprehensive review of that particular case and made a long list of recommendations linked to that. From a general mental health service provision point of view, NHS England have issued a number of requirements. And as you would expect, as we always do locally, we are looking at what else we can do that goes over and above to ensure that we can assure ourselves that our patients are safe, or as safe as we can possibly assure they can be, in relation to possible repetition in future, because we do everything we can locally to make sure we learn from these cases. That work is being led by mental health, but of course, given the links to patient safety, not only for the individuals who are users of mental health services, but also for every member of our public, there is a really strong quality and patient safety link. And we expect that once these reports have been produced and been through the various internal governance structures, we'll be bringing a more comprehensive report back from Quality and Safety Committee or a combined report that will outline exactly what we've done in the local area to seek that assurance. So apologies, quick canter through all of that, and some really, really meaty stuff in there, but very, very important work ongoing. And other than that, in relation to the main report, I'm happy to take any questions.
Thanks, Heather. I think what we'll do, if we could take Josie's escalation reports as well, because these are incredibly important reports and very full reports that we've got in front of us today. So Josie, could I ask if you'd just take those, and then we'll take general questions on the item.
Yes, of course. Thank you, David. And just to clarify for those that don't know how Quality Safety Committee works, we work on a bi-monthly cycle. So 1 month we have a formal committee, and then the next month we have a deep dive. Today you've got 2 reports, because during the deep dive session we had to also take some formal business. You would not normally have 2 reports like this. So that's why it's slightly different today for those that aren't as close to it as many of us are. So in terms of the August report, just a couple of things to draw out. We received the first quality report around the Gordon Street surgery, which obviously at the moment is being managed by a caretaker manager, and we were actually delighted to get some really good assurance that surgery is now in a much better place in terms of the quality and safety issues that were identified. So we were pleased to receive that. In terms of looked after children's health assessments, we still aren't quite where we need to be, and we're expecting a further report in October with hopefully some more firmed up trajectories in terms of returning that performance round, and we obviously will see that in a week or 2. Heather's already mentioned a lot around the LMNS, the local maternity and neonatal service, so I won't go into that. So in terms of the first report, I think that's actually all I wanted to say, David, really. But in terms of the second report from the 11th of September, I just wanted to highlight the report that we received around patient safety and quality in pressurised services. Again, we had a comprehensive report at the Safety and Quality Committee. We pushed back a little bit because the team felt they weren't compliant in a couple of areas. We felt that needed a review, and I believe that Heather as Chief Nursing Officer and Paul Edmondson-Jones as Chief Medical Officer will be signing off, has signed those reports off to be submitted on the 22nd of September, and very important piece of work given where we are in terms of moving into the winter, etc. So thank you, David.
Thanks very much, Josie. And as said a moment ago, a lot of important information. Just want to note, I think on the leader stuff, Heather, as you said, I mean, that is a fantastic result. And we've been concerned about that for quite some time. So ensuring that that particular group of our citizens within our community are receiving that level of scrutiny of their care, I think is really important. So well done to everybody in terms of that. I think also the deep dive, Josie, around the particularly the patient safety and quality of care in pressurised services. Again, it's great we've been able to take a system response to that and have some dedicated time to really get into it. And just finally, for me, on the mental health one, again, a really important piece of work in the light of the tragedy that occurred in Nottingham. And Heather will look forward to a steer from you and Josie in due course through quality and safety and back to the board. And perhaps talked about the Hatherton and forensic and acute inpatient services. It might be a good time to have a focused discussion around those elements of the service in due course, but I'll be guided by you. So I'll just take some questions. Julie?
Thanks very much, and thanks for those of us who weren't at those committees. I found the summaries really helpful, so thank you. I've just got one question around the workshops around EHCPs, which the importance of these I absolutely agree with. I just wondered how educators have been involved in those workshops because of the input from teachers themselves, but SENCOs within schools.
Yeah, thank you, Julie. Really good question. My understanding is, although if you'll forgive me, I will go away and absolutely confirm this, that education are absolutely linked into all the work that takes place on that special educational needs disabilities agenda. So they will be involved in the workshops. And even if you link that then back to the work we do around safeguarding, although there's no statutory requirement for educational involvement, we are strongly linking with education to make sure that they get the opportunity to contribute to all of those agendas. But I'll go away and get a more full response from our designated clinical officer, and I'll get that over to you by email if that's okay.
Thanks, Heather. Thank you.
Yeah, thanks for the question, Julie. Any further points anybody wishes to raise on Heather and Josie's very comprehensive quality and safety report? If not, in terms of enclosures 6, 7 and 8, we're being asked to receive the report and seek clarification and further action as appropriate, and be assured in relation to the key quality assurance and patient safety activity undertaken in respect of matters relevant to all parts of the integrated care system. So just to quickly look for agreement on those. Thank you very much. So Paul, can we move into enclosure 9, another important report, the summary report from the Staffordshire and Stoke-on-Trent Clinical Senate?
Yeah, and thank you, Chair. Again, I think I can probably be fairly quick with this. So purpose of the report is to provide a summary and escalation report, the items we discussed at our July meeting and any approvals we made in that meeting. This has been prepared by Rachel Gallio, as you know, chairs our Health and Care Senate for Staffordshire Stoke-on-Trent. Unfortunately, Rachel can't be with us today, so I'll present on her behalf. I'm going to assume that the report has been read, so I'll take it as read. And the only element, Chair, that I wanted to escalate to the board in terms of the report was around medicine shortages. And I think board will be aware that there have been all sorts of medicine shortages over the last few months, affecting both primary care and secondary care. It impacts services like imaging, and some of the shortages are actually quite a burden on the system. We have, in many cases, fairly limited responses that we can do, other than raising sort of awareness of the national guidance. Local implications that we get are around the amount of clinical time taken up in trying to source alternatives, which can take an incredible amount of time. And of course, the distress that it causes and the anxiety to both patients, residents, and also our clinical workforce. So the discussion really was about how we highlight these as a risk. I think currently we have a single risk around medicine shortages, and I expect that's the same on all of the provider boards. We had a long discussion about whether that should be more specific and we should raise specific shortages to the board. My concern is the time lag in doing that, because from the announcement of a shortage, it might be 3 months before we have another board meeting. By the time it comes through the governance, comes back to the board meeting, by which time we may well have sorted the risk out. So in terms of that time, it's really difficult to bring specific issues all the way up to the board. And I do wonder whether we just keep it as a single risk, where we know we've got medicine shortages and we know that the system will work at pace to resolve those issues. So that was the only issue that we wanted to raise to the board. The other one that I did just want to ask in passing, Chair, was whether this, to board members, whether this is the sort of report that they want to see coming through. It highlights quite a lot of detail, but it does mean that people then can delve in, have a look, see something, and then raise a question if they've got an issue about a particular thing. So really just that one thing about medicine shortages, and then is this the right format? Because I think this is the first time we've brought this to the board.
Yeah, okay. So I'll pull on that point in particular. I'll just pull in some other comments before I give you my comment.
Thank you.
Julie?
Thanks, Paul. Just I agree about a single risk. What I'm just a little bit worried about is in terms of our public listening today, who will be actually affected by these shortages, is how we are supporting them, communicating with them, and to prevent harm. My second comment about the report itself, which I found useful. However, I found some of the abbreviations quite difficult to follow. Certainly in the ONS prescribe, I didn't follow that very well. So I think there is something about remembering that people won't be versed in the same sort of language as those that are attending the actual Senate.
Yep, and
Thanks,
thank
Julie.
you. Sorry, Dave, I was going to say thank you, Julie. It's a point that we have to keep remembering, isn't it, about abbreviations and acronyms and so on. And you're absolutely right. And my apologies for that. And we need to make sure that we absolutely drive them out of that. The second thing I think is around the sort of the contact with patients. We do, and we contact as soon as there is a national guidance. Communications go out, we wrap around the patients that are affected, we work with them. As you said, it has been, it can be quite distressing for individuals, but we do wrap around each of them. I want to assure members of the public here that we absolutely do that, and we do that in real time. So our teams just get on with doing that sort of immediately, if you like, rather than waiting for any form of governance to go through. Chair, I can see that Simon wants to come in. He may want to support
thanks,
on
Paul.
that.
Thanks. Yeah, Simon.
Thank you, Chair. Thank you, Paul. I was just going to echo support for the format for this particular report, really. I think one of the things that's incredibly difficult to convey is the amount of discussion that goes into these items, as well as the amount of evidence potentially that's under consideration when decisions are made. So I think for the purposes of this board, it's very helpful to have a summary of those decisions without necessarily all the detail that went into making those decisions because of the volume involved. So supportive.
Yeah, thanks, Simon. So, Paul, I was going to make a very similar point actually on the report to Julie and Simon. I really welcomed the report because I think it sets out just the activity that's taking place across the piece, and obviously, we want to see this clinical and care-led, managerially enabled, and that it really brings that out. I think the abbreviation point I think is really well made by Julie. Just if we can, not only for the general public, for some of us lay members as well. So we all know what the abbreviations stand for. So I think that's great. The only concern I had, Paul, from the report was the difficulty with quoracy, and given the amount of important business that's been transacted through the Senate, I just could do with a bit of assurance, because obviously in the recommendations we are being asked to ratify the decisions taken, and presumably some decisions couldn't be formally taken on that day, so it's difficult for us to do that. So I just wanted to get a feel for the the energy and engagement, and people are attending to make it quorate, or that we're reviewing that.
Yep. So two things on there, Chair. Just in terms of the acronyms, I can assure you that even the clinicians don't understand all the acronyms either. So there are so many of them these days that share that. In terms of the quoracy, it's something that I've picked up with Matthew Lewis, and Matthew and I will pick up on that. We absolutely have to make sure that this meeting is quorate, it's attended. It probably needs to be extended, to be honest, for another hour to give us the time to go through it. And Matthew, I just having a discussion about whether it's on the right afternoon of the week, whether we need to change the time, what we need to do. And we also need standing deputies for everybody who's attending in order that we've got that quoracy. So just assurance that we're on it, and we will make sure that it's quorate.
Great, thanks very much, Paul. So if there's no further questions, we're just being asked to note the content of the report. We are being asked to ratify approvals, and Paul will do that where they were quorate and appropriate within the terms of reference for the Senate, and note and discuss the escalated medicine shortage item and the impact it's having on the system. And Paul, I think also just to thank Rachel for what she's doing in terms of driving this forward, because this is a really important arm of our governance, and certainly welcome the energy and drive that's been put behind this to get it to the current position, and hopefully take it to an even stronger position moving forward. Okay, thank you, colleagues. We'll move, if we can, to enclosure 10, which is the ICS finance update and the development of the medium-term finance plan, as Paul referred to earlier in the questions we received. So, Paul, can I ask you to take 10, and then we'll move into 11 with the performance report when you've done that with Phil.
Yeah, thank you, David. Thank you. The paper on finances covers month 4. We've got month 5 figures now, so I'll quickly reference those. Those have been considered and scrutinised on Tuesday at Finance and Performance Committee. So the month 5 position is very much a continuation of month 4, and the actual deficit at 63 against a plan of 37 million, so 26 million adrift. So unfortunately, the financial position continues to be very pressured and stressed. Our run rate is currently not where we need it to be to get to the year-end plan target of 90 million. We've signalled in the paper that we have getting off 100 million of risks that we are currently working our way through. One of those risks that we've been indicating all year is around out of system contracts. As we know, for Staffordshire, about 50% of our population is just short of that receive their care in hospitals that are housed in other systems. We have now, I'm pleased to say, agreed contracts with all of our neighbouring providers. So that's obviously good and important, but unfortunately that has meant that quite a significant risk has crystallised, and that's now included in the run rate. We brought that into month 4 position, which is in the papers in front of you, and that's obviously continued into month 5. We also referenced in the papers, we have now appointed a system recovery director. He reports to all 4 chief executives, importantly, or NHS chief executives, so that he has the ability to work with us across the system on all the system collaboratives, as well as the efficiency programs that take place within the individual organisations. As a result of the pressure on the finances, we put in place additional controls around payroll, and we believe those are working satisfactorily. We've also increased the control on non-pay spend. We have a lower limit now that managers have to work to, and that's resulted in additional scrutiny of all the non-pay costs. We're continuing to work through all the other options that we have for making further improvements. Those were discussed yesterday. We have a system performance group, which is a group of all the executives across the system. We came together yesterday and worked our way through some of those, and that is hopefully going to yield some further savings to improve the run rate. Capital, Ian asked about, and I mentioned the capital programme in year is in line, so we do expect to live within our capital allocation. So it does remain, extremely challenging, and we are still forecasting achievement of the control total, but there's a lot of stress on that, and we're continuing to work our way through it. I'll perhaps pause there, David. I was going to go on to talk a bit about the medium-term plan, so I'll just pause in case there are any questions on the current position.
Thanks, Paul. Just pause there for questions. And Paul, I think it's just worth minuting that obviously, as you described this, we are in a difficult situation with the money. I guess what I just want to emphasise is that we've got structures and processes across the system to get system partners, chairs, chief execs, chief finance officers, and the wider non-executive community engaged in discussions about how we are managing that without undermining our ability to provide safe, sound services going through that period. So just check if there's any further points for Paul on that. Okay, Paul, move into the second element of the report.
Thanks for the point you made there, David. I think despite the pressures, we are continuing to work together really, really well. And the other positive thing that I did mean to mention, the efficiency plan that we have for the year is 203 million. With the additional work that we've done the last few weeks, we're up to 180 million, which isn't enough, but is still probably the highest number the system has ever achieved. So although the position is so difficult, there's actually some successes there, and you're quite right. We continue to work collaboratively. And yesterday we had a number of clinicians and operational people with finance people working through, and we do the best we can working together with the challenges that we face. But so thank you for that point. If I can then move on to the medium-term plan, David. That's gathering some significant momentum now. You will recall that we had a conversation here about the establishment of this piece of work, and we've now got a working group in place, a task and finish group, which is doing some of the more detailed modelling, and then that's coming through the more formal governance process for sign off. And we've created what we call the do nothing activity model, which is really looking at what would be the levels of activity that our population will need, given that over the next 5-10 years we expect significant growth in both numbers and the age profile of the population. So if we did nothing further to what we do now, then we would see further increase in demand for acute care. So to Peter's point earlier about the work of DARS, that's why really that whole piece of work around looking at how we meet the needs of population in a different way into the future is so important, and therefore the importance of this piece of work around the medium term. And what we're looking to do really is show that if we work together across a range of areas, we can right-size the finances. We think it will take some years rather than 1 year, and that's the important aspect of this piece of work. We think your regulators are far more likely to back us and give us a number of years to bring about the turnaround if we've got a really coherent plan with strong analysis and strong commitment from all parts of our system, clearly clinical and operational being key to that in terms of delivering the targets of both safety and the other targets that we have to deliver our healthcare. We are breaking the tasks down then from that do nothings, we call it, into what would the position look like if we do interject the interventions that we think we can do to show, the plan is to show that we can therefore not see that level of growth into the acute sector, and working with colleagues at UH&M, for example, UH&M are not wanting to build more beds, more wards, a bigger hospital. That's not what they want to do. But clearly we need to work as a system to ensure that the activity that's going into the acute sector is manageable with what we have. So there are three kind of big parts to the work that we're doing. The first is being led by Paul Edmondson-Jones and the clinical team around looking at what are the clinical models that we want into the longer term to really make it work for our patients and work for our clinicians at the same time. And that's about ensuring that there's an equilibrium in the delivery of services from a clinical perspective. The second, which is a piece of work that Elizabeth is going to lead around the transformation of service and really the drive that's been described of putting more of the care through community and primary care in order to achieve the outcome of not having that growth into the acute sector. And then the third part, which will be led by providers, is about productivity. So we do know that we've had a growth in workforce in the past period since before COVID. So it's really about how can we put in place the right systems to enable that higher level of workforce to actually work in a more streamlined way to deliver more healthcare within the same workforce, and that way then we can bring about the financial improvement. So those are the sort of the three parts, David, to the work that we've got underway. A lot of enthusiasm for this, a lot of support. I do believe we've got the system working collectively on this across the piece. We'll obviously bring this back to the board over the coming months, and the plan is that before Christmas we've got a worked up model which kind of shows the art of the possible, and then we're going to then build the detail from there on in terms of the different elements over the course of the 5 years. So it'll be a case of building that detail as we go. But what we want to have quite soon, and Christmas is not that far away, by Christmas, to have that sense of, yes, actually we do have a plan here that we can deliver, that can bring about the financial results that we need over a period of time, and that will enable us to have hopefully some sensible conversations with regulators about giving us that time to bring about that transformation. So, Dave, that's where we are so far with the work on the medium-term plan.
Thanks, Paul. Again, very helpful update there in terms of all the work that's going on across the system. Just pause there. Any comments or questions from anybody? It looks like you've covered everything off there, Paul. I guess, Paul, the one thing that I continually think we need to reinforce is we seem to have arrived at a position where we're getting to one system, one plan, as opposed to, the historical position where there were many plans, and a system. And I think, the more we can do to get traction behind that, the better. I know there's work going on as well with local authorities in terms of how we can align our plans with their direction as well, which is really welcome.
Yeah, completely agree. And I think we've been getting better each year at that, I think, haven't we, in terms of that integrated plan. But we just feel like we're in a position to make another further step improvement in that, so that the plans of the providers, the plans of the local authorities, as you say, David, all dovetail into that overall system plan. Yeah, absolutely. Peter?
Yeah, I just wanted to kind of say that this piece of work is massively important, and of course we did an amount of forward planning for this year and for the previous year, but I think this is going way beyond the work that we've done previously, and it started actually a number of months ago when we, even though at that point we were very much sort of reacting to national expectations as all ICSs were, we realised the importance of going even further in terms of the planning process. So I just wanted to say a massive thank you actually to everybody that has put the effort in so far. I think the sweet spot is to ensure that we create a plan that's intelligent enough that describes well the challenges but opportunities that we've got going forward, but then doesn't go that far that we spend essentially an eternity on creating the plan itself. So there is a sweet spot that we're looking to land on that does enough from a planning perspective to clearly indicate the opportunity, and the fact that we'll have that narrative, that detail, and be able to build the solutions from prior to Christmas, I think is, as I say, unprecedented, I think, at system level. So just a massive thank you to the work done, but also, of course, for what's to come.
Thanks, Peter. Paul, thank you for the report. And just to note, the board is being asked to note the year-to-date deficit in month 4. Secondly, that the aggregated net risk has increased by 15 million to 103. And thirdly, the steps being taken to address the adverse position that you've identified. So if we can note those recommendations and move into item enclosure 11. Phil, will you take us through the top level performance report, please?
Yes, thank you, David. Okay, so I will take the report as read, but I would like to just emphasise a few points within there, particularly in terms of urgent and emergency care this time round. So we saw some really strong improvements during August. So ambulance response times for our population. For those with the highest need, we class those as a sort of a Cat 2 in terminology, and now consistently within the 30-minute standard. And the latest data we have suggests that we're actually within 19 minutes for our population. So that's really, really strong compared to where we have been in previous months and years. Similarly, our 4-hour performance improved by 3% in August against our planned trajectory. As we've come into September, we have seen some challenges with a step up in terms of demand and acuity, and that's very much being seen across the region. The 3 big ticket things that I wanted to draw attention to that we've been working on are firstly the new same-day emergency care facility at the Royal Stoke Hospital. Unit went live at the beginning of August, and we've seen really positive movement across several metrics around flow, including the 12-hour target, level of patients waiting for beds, and ambulance handover delays since that time. So really, really positive initiative that's been put in place. Similarly, a test of change has been completed down at County Hospital around frailty. So essentially to provide a frailty front door unit, a multidisciplinary assessment unit, which has again demonstrated reduced emergency admissions and improved performance and experience for our patients. And then the third one, I'm really, really excited about this, is our new Integrated Care Coordination Centre. So that's lots of I's and C's. Essentially, this is the 111 for care professionals within our system. It's the first port of call for those care professionals to contact in terms of trying to seek community-based support and response, rather than defaulting to ambulance, rather than defaulting to conveyance to hospital. So it's very much about growing our alternative pathways, delivering care closer to home, and really supporting that longer-term strategic left shift, which has been referenced by Peter at the start and by Paul just in terms of the medium-term plan. In terms of this, we've launched several pathways for community nursing, first contact and stay and well service. We've got pathways agreed for respiratory and heart failure, and then we're developing further pathways in the coming weeks as we head towards winter in terms of direct access into SDEC, same-day emergency care within the acute, access into social care first contact teams, and also referral pathways into hospices. This is very much the thing that we need to be focusing on and growing in the months and years ahead. And a really key founding principle of this centre is that it's no declines. So if a patient is suitable, the unit takes on the patient and finds an alternative provision. So in the same way that if an ambulance arrives at an ED department, an ED will accept the patient and treat them. That is the principle upon which the ICC is founded. Our current focus in the next weeks and months, firstly around developing the winter plan, which will obviously work its way through governance and come to this board in November. It is important to note, though, in real terms, we're dealing with less funding than last year and previous years because there's been no national funding announced. Last year we had additional funding via local authority winter monies. Previously it's come through NHS route, but we haven't got that this time, so we're working within our identified budgets locally. Obviously it's crucially important that we have the right capacity in place to deliver safe and high quality care, and we're also putting a real emphasis in terms of value for money, recognising the financial position we're in, so that those schemes we do put in place we know are going to have the most beneficial impact for our patients, and in terms of managing capacity for us. The plan's based on our previous learning and also based on the operational and clinical thinking nationally in terms of where we need to focus ourselves. So as I say, we'll come back with more on that. The more immediate challenge that we have is that we've been set a national challenge to reduce our ambulance handover delays to a maximum tolerance of 45 minutes. Our system will be in phase 1 of go live of this, so early next week we'll be implementing protocols around it. I mean, we have seen real improvements recently in terms of our average handover times. At one point, as we were coming out of winter, the average was over an hour and 10 minutes. We're now down to around 50 minutes, but clearly we need to go much further, and those figures are averages and we're talking maximums. It's recognised as a whole system challenge. We've got task and finish group in place with all system partners, and really strong engagement from everyone on this, including the ambulance service. It's ambitious to think that we can achieve this, but we're absolutely committed to do it. To give some context, at the moment we're for UH&M, we're around 65% of ambulance arrivals are handed over within 45 minutes, and it's around 74% over at Burton. And the plans that we're putting in place are to get us to a 95% compliance by December. I'll just touch on elective recovery agenda. Very much a dynamic position, so a couple of the numbers I may quote may be slightly different from within the reports, but I'm pleased to report that we're now forecasting 0 104-week waits for September. This has long been a challenge for us, but to be in a position of 0 is really positive. There is, though, comprehensive data quality work underway, focused on our risk cohorts, so we'll be reviewing the findings from that and applying any changes to the waiting list in line with national policy. Our 78-week wait cohorts are continuing to improve, as are the 65-week wait cohorts, but there is a real challenge, I think, nationally, and I certainly know for the region, in terms of meeting the target of 0 65-week waits by the end of September. In terms of 78-week waits, I think, based on all of the predictions I'm seeing, and that things move around a bit, but we'll have just under 20 for our population at the end of September, 8 of which will be likely at UH&M. In terms of 65-week waits, I think the risk cohort is numbering several hundred now, both in terms of where UH&M are at, plays into that picture, also UHDB, and then obviously the other organisations, RWT and beyond, who treat our population. I think we'll end up in several hundred by the end of September, so obviously we'll be resuming the push to 0 for October. Last couple of bits, diagnostics. We've got additional endoscopy capacity in place at County Hospital now, which is, I think, delivering really good yield in terms of working on both the live waiting lists and planned waiting lists. We do have challenges around non-obstetric ultrasound capacity within our system that we're working through locally and with regional colleagues to try and provide some additional capacity in that space. And from a cancer perspective, I think we're continuing to perform really well, both in terms of faster diagnosis standard and sustaining the backlog reductions. So a bit of a whistle-stop tour there, but hopefully covered some useful detail. Thank you.
Bill, thank you very much again. Your usual comprehensive report. couple of reflections, really. I think it's great the point you made about the agility to be able to respond to where we're going with the transformation, and the new work there, I think, is really welcome. Just a quick plea on winter, Phil. You're meeting, obviously, this is an ongoing thing. People often say winter never ends, don't they, these days? But you're meeting in November. When will the board and our respective governance machinery, when will we begin to get some fix on what those plans and the risks that you identified around the budgetary issues be available? And just finally, Phil, on that, it would be good to really, I know it's been a very difficult challenge, but the sooner we can eliminate the 78-week waiters, the better.
Yes.
Just in terms on the the performance data that we're sending back to the centre, and obviously in terms of the delivery to the local population. So those were just 3 reflections. I'll open it up if there are any points any member of the board wants to make.
Thank you. So do you want me to respond to those points now? Or?
Yeah, unless Simon, are you coming in on one of those?
Yeah, in overview, I think it'd be remiss for me not to. Thank you, Chair. Thank you, Phil. Just to, reaffirm, my commitment, the commitment of UHN, to all of those performance metrics. But as you might imagine, as we head into winter, I professionally believe that the clinical outcome measure of ambulance handover delays is one we really, really need to resolve sooner rather than later. That's down to UHN, but it's also, contingent upon system partners to assist with that as well. But just to reaffirm my commitment, I think, the greatest risk sits out in the community for patients yet to be risk assessed by anybody, let alone a big university teaching trust. So, we play our part in making sure that is handled appropriately. So I welcome the latest initiatives, and we will lean into that fully and comprehensively.
Great, thank you for that, Simon. So just on winter, Phil, just to get a fix on that, just back to the board when?
Yeah, so sorry to clarify, it will come to the board in November for final sign-off.
Right.
But we had a first talk through yesterday at the System Performance Group, really helpful face-to-face meeting with finance ops and clinical colleagues and workforce colleagues there yesterday to talk through some proposals around winter and distributing that spend. So we're working to lock down proposals in the next week or so. It'll then work through, obviously, Finance Performance Committee our side, but it'll also go to all of the public boards of our NHS providers and also local authority forums before it comes back to this board in November for ratification. But essentially what I'm looking to do is try and gain early agreement so we can get momentum on some of those schemes, because clearly you can't just push go on a lot of things and then the capacity's in play, that there's recruitment and bits and bobs to play into that. So we're building momentum on it, but the very final point for it will be this November board. Thank you.
That's great. Thanks, Phil. And presumably linking up with communications around vaccination programs, etc., with flu, COVID.
Yes, absolutely. The vaccination program is a really key component of our winter plan. Yeah, thank you.
Great. Thank you, Phil. So if there are no other points that anybody wants to raise on Phil's report, we're being asked to note the high-level performance against the 5 priorities and note the progress to date on the high-level key programme deliverables. Megan isn't with us, so Paul and Phil, can I just ask you to pull out any relevant escalations that have not already been picked up under enclosures 12 and 13? And Josie, you may want to just input into that as well.
I think from my perspective, I think I've pulled out within the performance update. Thanks, David.
Okay, thanks, Paul. Josie, is there anything from a non-executive perspective that you want to bring up that Megan would have brought up today?
Yeah, Megan and I have been in a bit of correspondence, so I've got a very few comments, David, if that's okay. So we just wanted to emphasise that obviously the committee is now receiving reports from the Recovery Director, including progress on our efficiency plan and collaborative stretch targets. In terms of capital, as Paul said in his presentation, we have got a compliant plan this year, but have a risk in 25-26, and we need to work on that. And Paul mentioned the 10-year capital plan submission. The main thing that Megan and I wanted to pull out was the clinical risk around the electronic patient record and lack of capital solution, which is forcing us down a do minimum plan, really, which we discussed in quite a lot of detail at the last F&P, and we've got a further F&P on Tuesday. I've know the papers are in, I haven't looked at the agenda, but we have got a big concern around that. And then we are still concerned about progress against priority 5, supporting care home residents, which you know has been an area that we haven't got traction on, really, not just within this year, but in previous years. So further work needs to be further work needs to go into addressing that. Thank you.
Thanks very much, Josie. And presumably on that final point, Josie, you've just made there is a plan to actually accelerate the oversight of that particular action, yeah?
I think that's been the request. We haven't had the discussion about where we are until probably Tuesday, I guess. Okay,
thank you. Phil?
Yes, thank you. Yeah, I mean, just to update in terms of that, I'm now picking up the SRO for the demand management system collaborative since Simon Evans has moved on to his new role, and we're very much keen to develop the care homes offer under that. So it's going to be very much a focal point of that system collaborative. Thank you.
Okay, thanks very much, Phil. If no further points on that, Josie, thank you for covering that off for Megan. We receive those reports and escalations from the committee chair. So item 11 and closure 14 is the people, culture, inclusion and insurance report. And Gemma, welcome. Thank you for covering for Mish today. If I could ask you just to take us through the headlines of that.
Apologies, Chair. It's Helen here, and I'll open up initially and hand over to Gemma. So just to give you a bit of an intro, I'm Helen Conway, ICS Strategic Workforce Planning Lead. Opening up section on behalf of Mish Irvine. I'll pass to colleagues on the call as appropriate. Also, just to add thanks for being able to share the opportunity of where we are with workforce, which is obviously our most important asset. So from page 92, it updates on people metrics, workforce assurance, people risk and programme delivery. I'll take the papers as read. I think the key points to take away from this is, as always, we continue to work really very closely with providers and organisations in the system to consider what our overall workforce position is actually doing, how we're performing. This does include the bank position because you'll notice in the document that it does state that we are above plan. So we are really trying to get underneath some of the drivers for this and understand the areas of opportunity for improvement. But it's also worth just flagging from an agency perspective, we are doing reasonably well in that area, actually, more than reasonably well. The target that is set from NHSE for that is 3.2% of total pay spend. The system are currently achieving 2.4. That's by no means do we rest on our laurels, because we know that there's further opportunity in terms of some of the high spend areas. We're also building an oversight approach which builds on what we've had to date, so just brings into account how we work with providers, how we share information across the system from an MDT perspective, but it also utilises NHSE endorsed data intelligence and insight approaches. This means that we've got a really balanced approach to understanding the areas of opportunity, but also to understand the areas of improvement for good practice and to share the good learning and understanding from that. This will provide an opportunity to really ensure that we focus and align our resources effectively to the priority areas that are needed. And without further ado on that very subject, I'll now pass over to Gemma Trainer, who's on the call.
Thanks very much, Helen.
Thanks, Helen. Thanks, Chair. So just to take us through the last couple of elements of the people and workforce section. So 3 areas I wanted to just pick out were the PCI committee review, and that's detailed in the pack, but a good, robust piece of work's been undertaken with committee members to strengthen the way in which the committee operates, to bring it in line with the other committees of the ICB board. So a couple of points to note in there. We've now moved to a monthly committee, and we've strengthened the subcommittee structure that sits underneath that as well. And that's so that we are really kind of able to focus more regularly and provide assurance and oversight on the people and workforce elements that have been referenced earlier. We are going to be reviewing the reporting and the highlight structure that sits underneath that as well, and just requesting approval from the board on that, and that is mentioned in the PCI highlight report as well. Risks and challenges is mentioned in there. I won't go through those, but because they'll have been referenced and well known to us, but just assurance to the board that they are being managed, and mitigation is in place via the PCI committee, People, Culture, Inclusion Committee. And then just finally, as Helen's referenced, the programmes that then sit underneath that to mitigate the risks, the challenges, and to bring us together in delivering the long-term workforce plan and people plan are detailed in the pack. That is a very high level overview of the programmes, and referenced in the pack is that we are going to be undertaking that review of that reporting. So the report that comes to a future ICB board will look slightly differently in connecting the programmes to the risks and our priority areas, but no escalations from a programme and risk perspective. Thank you, Chair.
Thank you very much, Gemma, and again, thank you, Helen. It appears to me that the dial's moved quite considerably on some of these things. And Helen, you talked about the agency use there, moving from 3.2 to 2.4. And as we know, we were receiving, understandably, a challenge from NHSE on that earlier in the year. We've got a quarterly review meeting coming up into October, I think it is, Peter, when we meet with the team again. I think the presentation of this is going to be really important there, given the financial challenges that we face. And Helen, you talked about the bank side of this, just getting under that, as you described, and getting a bit more narrative that we can play into that meeting would be helpful. But overall, the presentation of this report I thought was very clear and very helpful. But I'll open that up for any questions. Helen, you just want to come back on that point?
Yes, if I may, Chair, just in terms of probably how I've communicated the agency element there, just to clarify, the 3.2 is the NHSE target that is set to all providers in the country. So at the moment, we're performing as a system at 2.4. So it is really an amazing achievement that we've got to that point.
Yeah.
It does mean that we are seeing more reliance on bank, which we need to understand. But overall, the picture of that would be that bank would generally be a lower cost option than agency. And also just to consider potentially quality issues there in terms of the resourcing options that we've got available to us and how that's been used.
Yeah, very helpful, Helen. Thank you for that. And if we can bring that out, as I say, in the pack as we go to the meeting with NHSE, I think that would be very helpful. Can I just check if there's any further questions on this report? If not, on the escalation reports from Showcat, Julie, I think you're taking enclosure. Is it, what have I got there? 15 and 16, just had to squint there.
Yeah, thank you. Just on behalf of Showcat, I've taken them as read. Gemma and Helen have gone through the detail. I just wanted to say a couple of things, really, 3 things. We are continuing to strengthen assurance arrangements, as you can hear, but it is really important that we ensure continued engagement with our partners, because this was a committee that really was well engaged within the system, and we need to make sure that continues. The one thing that we talked about a lot was the importance of the triangulation of activity, workforce and finance, and that will continue to be a priority in the way in which things are presented. The other thing I just did want to mention was that, and just to say again, the civil unrest that occurred earlier in the year and the actions that were being taken to support our colleagues, I think we have to acknowledge that that fear still remains, and just ask people to check in with our colleagues to make sure that they're okay.
Yeah, really important flag there, Julie, that just brought up there at the end. Julie, can I just check, does that cover up enclosure 17 as well?
Yeah.
Yeah, thank you. So just pause if there's any item or issue anybody wants to raise there from Julie's report on behalf of Showcat. If not, we receive those reports for assurance and note the workforce position, operational plan, risks and mitigations in place to address that. So thank you, Julie. And once again, Helen and Gemma, thank you very much for those reports. So colleagues, that takes us to any other business. I've had no any other business notified to me in advance. So just pause in case there is any mission critical, any other business that anybody wants to raise. No. Okay. So if we can, Tracy, if we can just take any questions now from any member of the public joining us, I'll invite any questions on any item we've covered off today during the agenda. Welcome, Ian.
Hello, Chairman. Hello, Board. Interesting meeting, and thank you for the comprehensive responses from the two Pauls and Helen earlier on to my questions. Welcome what was being stated about a real integration plan, a systems approach, etc., etc. It's obviously very important that all parties buy in, underline, and whether that will mean vigorous debate and sometimes disagreement, so be it. I'm glad to see that Stoke-on-Trent were here today, and this isn't personal. I'm a Stoke-on-Trent resident, and I was astonished that Stoke, in the previous ICB board meetings, there was no representative for Stoke. For me, that is bad optics. It's my own viewpoint, obviously. It isn't personal, but Stoke's voice needs to be heard on boards like this. Right, I'll get on to my question. I'm not being impolite either. I thought that point needed making. My questions is, this 9.6 million binding conciliation, can I have clarification on that, please? I presume it's for people who've either had emergency treatment or elective treatment outside the geographical boundaries of the ICB, and have anything positive out of the negative. You can get positives. Has there been any learning processes that can benefit the future of the ICB?
So who wants to pick that up? Paul, Peter, Paul, probably. Yeah, Peter.
So Paul, I'm sure will be able to come in on the sort of the technical side of things. What I would say from the learning perspective is that Ian, and really good question by the way, is that the way that contracts nationally are managed, or the contractual processes that we abide by, I personally feel Staffordshire is negatively impacted by, and there's a lot of technicalities that underpin this, but essentially contracts out of area, we're only allowed to apply I think it's 1.1% efficiency factor to, and of course contracts in area, those that we host, provided that we host, we discuss and agree a tariff deflator rate of our own, and in system, as the papers have shown, it's sort of heading towards 6 or 7%. Now, when you're a sort of net neutral importer and exporter of services, as in, you know, you export as much as you import, that doesn't really matter. But because we export a huge amount of our activities and we're only able to apply a 1.1% tariff deflator to that, that means that we're kind of uniquely impacted across the whole of the country by that problem. And it's millions of pounds. It's not hundreds of thousands of pounds. So as much as I'm talking to NHS England about all of that, because we are by far and away the biggest net exporter of services, and I think the next one is Lincolnshire, but we're a long way away from them, there is this financial problem, and of course there's also the clinical and operational challenges that out of area providers being able to influence them also brings. So I think the learning for us is that we need to be more vocal and bring to the table with NHS England more often the unique nature of the Staffordshire system as compared to all other 41 systems. So that was my point on it. I don't know whether Paul wanted to add in terms of other technical financial aspects.
Thanks, Peter. Paul, anything you want to add to Peter's summary there?
Yeah, just the more technical bit, as Peter said, to you, Ian. So yeah, so the way we buy our acute care out of system is basically in two categories. There's elective care and there's urgent care. So elective care, simplistically, it's not quite as simple as this, but basically is whatever volume is provided, and we receive the money for that at the national tariff, and we pay that national tariff to those providers. So it's neutral, and we obviously encourage, therefore, providers to do as much as possible, because the more that's done, the more we can reduce waiting times. So that part of it's fairly straightforward. The urgent care side is a bit more, I suppose, in the category of changing, because before, you'll remember, Ian, before COVID, there was the tariff and payment by results was in existence. During the COVID years, effectively, all of urgent care got brought into an urgent care contract. So it was a block contract. And we now moved into, I suppose, a bit of a combination of the two, and that was really the conversations that we were having with the Black Country providers, was around how we pay for that. So we've agreed that we need to pay for the higher volumes that they're seeing in those hospitals. That's our responsibility. They're our patients. The issue is about how much you pay for it. I think, just to add to Peter's learning, which I agree with, just to add to that, it has reinforced to us the need to work, with out of system hospitals in much the same way as we do with system hospitals. So we're increasing the dialogue now that we have with particularly university hospitals, Derby, Burton, and Royal Wolverhampton Trust, because those two organisations account for the bulk of that outflow. So that's hopefully, Ian, that explains some of the technical changes that have taken place.
Ian, just to cover off the earlier point without getting into a debate about it here, I just wanted to give reassurance that all of our system partners are fully aligned to the plans and fully committed to the process and meetings. So meetings with all partners take place monthly in the board meeting, but also on a regular basis outside of the board. So sometimes there are some pressures on diaries, but the overall commitment is absolute to getting to one point where we have one plan for Stoke-on-Trent and Staffordshire. Ian, any questions that you wish to raise?
None. I've got obviously the AGM, and I take your point, David. As I said, that wasn't personal. It's the optics that don't look too good.
Okay.
That's the whole thing. And I'm well aware people work hard.
Yeah, Ian, as always, we're taking it in that spirit, and as I make the point to you every time you attend, it's really important that you give this commitment to the board, and we welcome the level of the questioning that you put us under, and I look forward to seeing you at the AGM. Thanks for your question, Ian.
Cool, thank you, board.
Right, can I just check any other questions from anybody who's joined us from the general public today? If not, we'll begin to bring the proceedings to a conclusion. So just in terms of meeting effectiveness and the compact I referred to at the beginning of the meeting, just wanted to check that all board members have had ample opportunity to raise any issues that they wanted to raise today and are not leaving with any concerns, that they haven't had that opportunity, and that everybody feels that we've conducted our business along the lines of the compact. Speak now or speak to me afterwards if anybody has any feelings about that. If not, we will bring the meeting to a close. The date and time of our next meeting is the 17th of October, 1 o'clock. That will be held in public via Teams once again. So thank you everybody for your attendance and contributions.
Thank you.
Thanks, David.